So pelvis and the lower limb, the hip girdle and the lower limb. There are a lot of similarities in this section compared to the upper limb that we just finished exploring. Very similar structures. Some of the muscles even span similar origins and insertions and have similar actions. There are some parallels. They're not the same, the names are different, but this shouldn't be a blast of new information. There's some familiarity here. So the pelvic girdle or the hip girdle, we've seen already. There are two hip bones that articulate with the sacrum that make up the hip girdle or the pelvic girdle. And really I'll probably just call this the pelvis. Two bones plus the sacrum that make the pelvis, and that sort of flies in convention of what you've learned in lab. It's not completely different, but those two hip bones are themselves made of three bones that fuse together. And they're so fused that it's hard to tell them apart. There are no sutures like in the skull. There are no clear lines or divisions. If you had the hip bone and had to guess if they were three bones or one bone, in an adult where it's formed, it looks like one. Those three bones are the ilium, which is one of the most characteristic, obvious features of the hip bone, the ischium or ischium, that jumped ahead, and the pubis or the pubic bone. And those three make up one hip bone. You've also heard those called coxal bones or os coxa or ossa coxa. Many different names. I'm calling them hip bones. So they articulate with the sacrum at the back. And we've already discussed the surface on the sacrum that articulates with the hip bones. We did that in the axial skeleton section. We'll revisit that. And then anteriorly, again at a familiar structure, the pubic symphysis. That little disc of fibrocartilage that allows the hip bones to articulate and bend and flex somewhat. Articulates at the anterior surface, at the pubic symphysis. So we know what a pelvis looks like. We don't have as much experience with the hip bones per se and the features of those bones, which is why we'll spend a little bit of time here discussing them. A little bit of time discussing them. So you can see at first glance the three regions of one hip bone. One hip bone shown here, and the three regions are colored, showing you the individual bones that make up the coxal bone. Ilium is the biggest, most superior. Pubic bone, most anterior. Ischium or ischium is most inferior. And there are many different things to look at, as you can imagine, with all of the names written out on the side. I just want to draw your attention to a few that I think are important. So one hip bone, looking here at some of the major parts, and one of the most easily distinctive surfaces is the ala, or the wing of the ilium. And that's this highlighted area here. This whole feature is the wing, or the ala of the ilium. The other defining features of the ilium, the iliac crest, this highlighted pink area, the entire top ridge of the ilium is the iliac crest. Major insertion point for some muscles of the back. Latissimus dorsi is one of those. The entire top surface is the iliac crest. And you can feel the anterior portion of that as your hip bone right now. There are a few defining features. There are some spines that we're going to refer to when we get to the muscular attachments coming up later this week. There are two pairs that are obvious on the ilium, and both pairs very similar. On the anterior portion, I've highlighted here the anterior superior iliac spine. So it's the most superior on the front portion of the ilium. And you can imagine that's paired with the anterior inferior iliac spine. So the name gives away what we're looking for. And these are paired with a complementary set of spines on the posterior aspect of the ilium. Their names you can probably guess. Posterior superior iliac spine and posterior inferior iliac spine. So those are clearly observable. There are many little lines and grooves and tuberosities, but the obvious features are what I want to look at here. What else is obvious? What else is obvious? This is a pretty obvious feature. The greater sciatic notch is part of the ilium as well. Mostly part of the ilium. Greater sciatic notch allows the sciatic nerve passage from the axial skeleton down to the limb. The thickest nerve in the body, biggest nerve that supplies most of the extensors of the knee. Greater sciatic notch. And this is a structure we'll come back to as well, the arcuate line. The arcuate line. And it's emphasized here. It's not so obvious on some specimens. It looks like a bending of the ilium. And this is a theoretical border. This is part of a theoretical border or a division that we'll talk about shortly. As far as the ilium goes, other than one last surface, there's not a whole lot that we need to concern ourselves with. And that last surface is the auricular surface. Remember ear, or auricular, meaning ear, looks like an ear. This is the surface that articulates with the sacrum. We've already seen the auricular surface of the sacrum. And it matches up with the same, or a surface of the same name on each coxal bone. So you can imagine the sacrum in between these two hip bones, making the pelvis or the pelvic girdle. Now there's not a whole lot to the other two bones, but it's worth bringing them up. The ischium, or the ischium, depending on how you want to pronounce it, has one branch and a main body. And so the body is shown here. And its major role is in supporting your weight as you sit there attentive. The ischium's major role is in supporting your weight as you sit there. And what does that specifically? Is the ischial tuberosity, the lower portion, the lower arm of the ischium itself. This is the surface that you're sitting on currently. And this is the surface that if you didn't have nice cushy chairs would start to ache after a while if you were sitting on a hard plastic chair, like in lab. This is the surface that's fairly superficial. You could palpate it if you wanted to. I won't ask you to do that now. It's a little personal, and your ischial tuberosities are indisposed currently, inaccessible. Well, that's its major role. That leaves the pubic bone, which is at the front. And the pubic bone has two arms, a superficial or superior arm and an inferior arm. So the body is at the point where they articulate, at the pubic symphysis. The body is highlighted here. And the superior arm and inferior arm are as you would expect. And here they're called rami. We've heard of rami before. One ramus, two rami. They are branches of the pubic bone. And the pubic bone, other than articulating at the pubic symphysis, helps to continue that imaginary border that we just talked about. So highlighted here, and I'm showing you this picture because it doesn't show the pectineal line specifically, but this highlighted purple area is the arcuate line we just talked about. If you continue that anterior onto the superior ramus of the pubis, you find the pectineal line. And this is a continuation of that imaginary border, or that bend in the hip bone. So that's important for our categorization and some distinctions that we'll come up with later in the lecture. Now there are a number of other things that you can identify and memorize, but those are the ones that I want to focus on in class and that you should focus on. I haven't mentioned one obvious feature yet, which is now most clear here, and that's the socket of the hip joint, otherwise known as the acetabulum. And I show it here because it shows really nicely how all three bones of the coxal bones meet in that depression, in that cavity. They all come to a point and all three bones make up the entire surface of the acetabulum. But we'll see that a bit more in depth as we explore the hip joint and the femur itself. That's a very nice deep socket, unlike the glenoid cavity, which plagues myself personally. So that acetabulum is where the femur articulates. That is one of the primary weight-bearing joints in the body, the two hip joints. The two knee joints and the two ankle joints are what I would call the other primary weight-bearing joints in the body. But the head of the femur fits into this acetabulum, making a nice deep ball and socket. And you saw on the last slide that all three bones fuse together, making up the wall of that socket. And look, when you get to lab, it's impossible, nearly impossible, to pick out the divisions between these bones. And here especially, you'd imagine the smooth inner surface of the acetabulum wearing down, blending together over time. It'd be really hard to pick them apart in the acetabulum proper. Now I'm going to add some things, some features to the pelvic girdle when we get there, but this is our basic understanding moving forward. Now I want to talk briefly about that imaginary division that we talked about. And here we have a nice example of what I would probably guess is a female pelvis, and we'll talk about that distinction coming up. And this is used to articulate the division between the pelvic cavity and the abdomen. Those lines that we talked about, the arcuate line and the pectineal line, if you follow them around the circumference of both hip bones and then draw an imaginary projection along the back of the sacrum, you can create an imaginary flat surface. And that border divides the abdomen superiorly from the pelvic cavity beneath. We call this the pelvic brim, the lip of the bowl, if you will, the pelvic brim. So this defines the border. If you are in the ilium on the surface here, if a muscle arises from the ala of the ilium, it's in the abdomen. If a muscle arises from the inferior ramus of the pubic bone, it's in the pelvis. So a clear delineation between the abdomen and the pelvic cavity. You can see it also highlighted here, and the next slide does a really nice job of trying to separate these out a little bit. But you have a nice side view here that draws the border that we just talked about. This is now male pelvis. And I'll tell you why I can think that in a second. But the imaginary border now split between the abdomen in red, the pelvic cavity in blue, and you can see the sacrum on the back portion of the pelvis as well. Now all of these bones make up the pelvic girdle, but technically if we assume or if we accept that that border defines the abdomen versus the pelvis, we can think of it in terms rather of false versus true pelvises. And I say pelvises, the book says pelvises. That doesn't really make that much sense to me. I'm going to stick with pelvises as the plural. The area superior to this imaginary border is the abdomen, or you can also think of it as the false pelvis, or the greater pelvis, the larger pelvis. And if that logic follows through, the pelvic cavity is not false, but it's true, and it's not greater, but it's lesser. Simply ways to describe the areas of the pelvis. So the brim, those lines, that theoretical division is what we use to separate these two ideals. So female pelvis previously, I'm pretty sure male pelvis here, and then on these two slides as well. Turning now in an anterior view, you can see the same color divisions for the false greater pelvis above, the abdomen above, and the pelvic cavity in blue below. So the false pelvis we don't know these structures yet, but it would contain the small intestines for both men and women. It would contain the ovaries, the fallopian tubes for women. We'll get to those in depth in the reproductive section. The uterus would be generally in this area as well, whereas the true pelvis or the lesser pelvis would contain the bladder and the rectum for both sexes. The cervix and the vagina for women is in the true pelvis. The prostate for men is in the true pelvis. So this helps us to describe the areas and expect what structures to look for in those areas. We're going to spend some time talking about the musculature in this area when we get to the section on muscles. That's not a major focus of lab. I expect it's because that's covered in the reproductive system as well. But a major success of the pelvis and the pelvic girdle is having, imagine this large open outlet on the bottom that nothing falls out of. That's a pretty major success. And a lot of that success comes from muscles of the pelvic floor that hold all of those structures in place and supported. So we're going to talk about those muscles when we get to that section. A major success of the pelvis is to contain all of those structures. So these, I'd argue, are male pelvises, and we saw an example of a female pelvis, and I'll show you the difference between those two here. There are a number of distinguishing features that you can call upon to define male versus female, but there's a few that I think are better representations than others. In some senses, you can even just get a feel for it. It looks like a male or a female pelvis. And the general look, a male pelvis tends to have larger, thicker bones that is a bit more narrow. It's a bit less open, a bit less wide, a bit more narrow. So the female pelvis, on the other hand, has less thick, less heavy bones and is more open. And this is the first major sex difference that we've encountered types of joints are similar, the brain structure is similar, cavities, divisions, muscles so far are similar. This is one of the first sex differences that we've encountered. It's not the last. The whole reproductive system is a sex difference. But this is the first one we've encountered. Until this point, we could have been in either men or women. But obviously, there are some clear biological differences, and the pelvis is one of the manifestations of that biological difference. Childbirth. The pelvis is structured in women to facilitate childbirth. Wider pelvis, more open, fantastic for childbirth. I would not want a more narrow pelvis in giving birth to a child. Side by side in the book, there are at least 2 tables that show you differences. There are nice models in the lab that also articulate the differences where you can see physical specimens. There are innumerable descriptors: shallow versus deep, light versus heavy, less curved versus more curved. In the anterior frame of reference, I think there's a few that are more telling than others. One, the size of the pelvic brim or the pelvic inlet is obviously different. Larger, rounder in women, more heart-shaped and angled or pointed in men. And I'm trying to pick out the characteristics that might allow you to identify male versus female without having both to compare. So these are some characteristics that I think are fairly obvious in and of their own right. If you're looking at these 2 examples side by side, you can say, oh yeah, that's bigger than the other. It's more open than the other. If you see the models in lab, it's easy to compare and say, yes, this versus that. But if you saw one example, it's hard to know immediately which is more open, which bones are thinner. So these are some examples of characteristics that I think will help with that. The shape of the pelvic brim or the inlet is an obvious tell. The angle of the pubic arch is an obvious tell. This angle down here, less than 90 degrees, very acute, much more open in women than in men, an obvious tell. And it's rare that you'll have one in the middle that could be either or. They're usually pretty telling. Also, a feature that we didn't necessarily discuss at first when we talked about the hip bones, but these holes that are encompassed by the pubic bone and the ischial bone are the obturator foramen. And they're not important now. They're mostly closed off. But we will see that they allow passage of some nerves and blood vessels when we get to a more in-depth view of the musculature in that area. But they are shaped clearly differently in men than in women. Much more oval and round and open in women, closed, narrow, pointed in men. Another obvious tell in a different frame of reference or a different point of view, and you can see some of those other ones transfer over here. The opening, the pelvic opening is different, obviously. I really like looking at the angle of the sacrum. From a side view, a lateral view, the space between the sacrum and then the hip bones itself is obviously telling. And look from the side of the models in labs, you can see exactly what I'm talking about. Much more closed off, the coccyx tucks under in men, whereas it does so less obviously in women. So I'm going to jump back just quickly, and I want to see if you would agree with the assessment. This is the first example of a pelvis that we looked at. I'm looking at size of the pelvic brim, obturator foramen, and the pelvic arch, the angle of the pelvic arch. Obviously, to me, female pelvis. Versus the last examples that we saw, dividing the false and true pelvises. Much more narrow angle of the pubic arch. Much more narrow and pointed obturator foramen. It seems like the pelvic brim is a little narrower, but that's hard to tell in a bubble. Still, that combination would lead me to believe that that's a male pelvis. Agree? Disagree? Okay. So let's talk about the hip joint proper. The hip joint proper as our introduction to the femur, and I'd like to get through this and maybe an introduction to the femur before we call it, but certainly the hip joint. And it's a fairly intact, straightforward joint. Not so many accessory structures like we might have seen at the shoulder joint. Let's look first at the ligaments. So from the outside in, there are a few supporting ligaments, and then the capsule around the ball and socket joint. And notice the amount of coverage of these ligaments. So we have full coverage from the superior aspect of the pubic bone, the inferior aspect of the iliac bone, all the way to this ridge over here. And we'll talk about some characteristics of the femur coming up. Maybe I should just do it now since we have it on the slide. It's not new because we've already introduced the greater trochanter of the femur, and you'll see it in lab as well. You can feel it just below what you would consider your hip, and the trochanter is a label that we've applied only to femur tuberosities. When we talked about features of bones, I made that point. Trochanter, greater trochanter, massive, large protuberance or tuberosity on the hip bone itself. And there's a lesser trochanter, more medial and posterior. And I bring those up because there's a raised ridge between them called the intertrochanteric line. And this is the insertion point for a lot of these ligaments that secure the hip joint. The hip joint's already very secure. It's a deep ball and socket. There's a lot of surface area. There's even a ligament that connects the head of the femur to the pelvis. But this helps to secure it even more. And so, let's take a quick look. The names of the ligaments give away their location and their structure. The iliofemoral ligament is pretty large, encompassing most of the superior aspect of this joint, connecting between the iliac bone and the femur. Iliofemoral. Makes sense. Obviously inserts all the way along that intertrochanteric line. Many of these ligaments insert on that intertrochanteric line. The pubofemoral ligament also inserts on the intertrochanteric line. Let me hide this guy. Not as far or through the entire range as the iliofemoral ligament, but certainly same area, same insertion. The last major ligament is on the back, and you can't see it. You don't have the slides, never mind. It'll be on the next slide that I bring up. The ischiofemoral or ischiofemoral ligament. From the rear aspect of the pelvis, the ischial bone, over the superior aspect around the neck of the femur, again on the intertrochanteric line. It's very secure. Of course, we also have the capsule itself, like any good synovial joint, synovial membrane, and then we're left with the head of the femur in the acetabulum. Now let me pop out for a second before I show you the ligament of the head of the femur, which also helps to anchor the femur in that cavity. So we talked about these. You can see, oh, I didn't highlight it. The ischiofemoral ligament here, same processes over the neck and wrapping around the greater trochanter. What we can't see, obviously from any superficial point of view, is this fellow right here. Ligament of the head of the femur. There's a ligament inside the ball and socket joint that connects from the edge of the acetabulum into this central depression of the femur, right smack dab in the middle of the head of the femur. And you can't even really see it in this example. This is the ligament of the head of the femur, as viewed from the outside with all ligaments and the capsule removed. That little green highlighted area. But it's nice. You can see it a bit more easily. As I fade everything else, you can see the border along the edge of the acetabulum, and then it culminates at one round point, smack dab in the middle of the head of the femur. And I really kind of think of this as insurance. It doesn't do a whole lot to keep the femur secure in the socket that the socket, the labrum, the ligaments that are around the hip joint don't already do. But it's kind of like insurance if you were ever to dislodge the femur somewhat. This central depression is called the fovea of the femur. You've heard that word before, and we talked about the eye. And there's also some blood flow and nervous innervation that enter the femur at that point. And so this is a perfect introduction to our discussion of the lower limb, where our first bone of interest is the femur, from the hip joint, articulating with the acetabulum. The femur is of interest because it's the largest bone in our body. Longest, greatest by mass, largest bone in the body. The head of the femur is large, very round, protrudes a fair amount, more than the head of the humerus, because as it fits into the acetabulum, there's a lot more surface area to articulate with. The cavity is deeper. That articulation allows the movement at what we know as the hip joint, and then the distal end articulates with the tibia. And the patella. The point is correct. The tibia and the patella. So at the knee joint, which we'll come to in depth in class on Thursday, we'll look at the tibia and the patella. But as far as weight support or weight-bearing joints, the femur articulating with the tibia is the main articulation of the knee. Patella has a very special process and function, which you'll see in lab in a really nice demonstration. So let's just introduce the main features of the femur that we haven't already mentioned. And a lot of them we have already mentioned. And then we'll call it for the day. I'll save the patella. We were going to talk about the patella, but I'll save that for when we get to the knee joint, which is a few slides down the road. Let's just look at the femur itself. So like the pelvis, a fair amount of information. A lot of these names probably make intuitive sense. Lateral and medial condyles without being introduced to them on the slide. Lateral and medial epicondyles, surfaces above the condyles. We've already introduced the greater and the lesser trochanters, specific tuberosities that are in application to the femur only. Their functions will become a lot more clear when we talk about the origins and insertions of muscles. Most of these prominences are for landmarking the origin and insertions of muscles. We already talked about the fovea too, didn't we? So greater and lesser trochanters, we've seen greater trochanter, lesser trochanter. The border between these two shaded areas is the intertrochanteric line. What is also of interest that we haven't talked about yet, on the back of the femur, where many of the adductor muscles insert and the knee flexors originate, this long, rough surface on the back of the femur gives rise to the gluteal tuberosity. Muscles of the buttocks insert here, and the linea aspera, where some of the adductor muscles insert as well. Obvious roughened longitudinal line along the back of the femur. And really, as far as surface features go, there aren't too many more that I want to articulate. The only thing that I want to bring up before we close is differentiating left from right. Differentiating left from right. So given a femur, there are a few characteristics that will allow you to differentiate left from right. One of the obvious ones is the curve of the bone. Viewing it from a lateral point of view, shown here, the femur curves backwards, bends slightly backwards. But if you didn't know that, it's somewhat difficult to determine if this is left or right. If you're not given a view of the curve of the femur and you're just left saying, okay, well, there's a greater trochanter and a lesser trochanter, it looks like there's a line between those two. There's the neck and the head of the femur. Which way's which? The most telling features to me are at the bottom. The most telling features are the articulation with the tibia, other than, of course, the curvature we just addressed. So, the femur articulates with just the tibia at these two condyles. There's the medial surface and the lateral surface. And so knowing those names, you can tell which is which. But if you didn't have those names, one defining feature of the articulation at the knee joint is this, the space between them. The space between the condyles. On the front, there's a third facet. This is the facet for the patella, for the kneecap. So it tracks superior and inferior, up and down. On the posterior aspect, you don't have that same articular facet for the patella. What you have instead is the intercondylar fossa. Between condyles, fossa depression. Intercondylar fossa. So obvious difference between the anterior portion shown here, smooth, uniform articular surface, versus the two main prominences on the back with the fossa in between. Easy to identify left from right using those, as well as some other features that we've discussed so far. So let's leave our discussion there for now. We'll come back with an exploration of the patella and the knee joint, and then muscles on Thursday as well. There's not a lot of bones to get through.